press and hold the mute.
Hello, everyone. We have the pleasure of having Dr. Moorman joining us today from the Department of Internal Medicine. His title is Professor and Chief of Infectious Disease, Vice Chair for Research and Scholarship, and he is also co-director of the ETSU Center of Excellence on Inflammation, Infectious Disease and Immunity in the College of Medicine. He trained at the University of Virginia for both residency and fellowship, and joined their faculty, completing his PhD in immunology while on faculty there. He joined ETSU in 2001 and has been active in building a translational research program in the area of viral infections generally and HIV specifically. While his training as a physician scientist in the fields of molecular virology and cellular immunology and infectious diseases is, I would say, impressive enough in itself. His research is focused on studying the interaction of viral proteins with host immunomodulators as a means of understanding mechanisms of infectious disease in humans, and in the past several years has served as PI or co-PI on several university and NIH-sponsored projects. He's established a large ETSU VA specimen repository to serially collect clinical samples for translational studies of chronic viral infections, and has established a multidisciplinary group of investigators, which I have recently joined in that COE. His early work focused on lymphocyte apoptosis, or programmed cell death, and the recognition that chronic viral infection induced a form of immune exhaustion. Subsequent studies he did identified a set of key negative immunoreceptors and transcription factors upregulated in host immune cells during chronic viral infections. Upon recognizing the dichotomy of immune exhaustion and immune senescence exhibited in both HIV and HCV hepatitis C virus infected patients, he explored in greater detail the role of microRNAs in controlling immune cell responses and negative immunoreceptors during chronic viral infection. This is an area we plan to explore together in the clinical aspects in terms of looking at HCV and HIV co-infection and its relationship to severe cognitive impairment. So without further ado, I turn the podium over to John to lecture us on the provocative title, HIV and Dementia, What the Future Holds. John?
Go ahead and use this until she can get me a new battery for this. So I want to thank Dr. Goodkin today for inviting me to come to talk to you. I've been working with some of your group already, and I think there's a lot of exciting things down the road in this area. I'm going to talk about HIV and dementia, but in particular talk about HIV and how it impacts our area a little bit, so you have a better understanding of what we're dealing with. And I'm going to hit on lots of different topics related to that. I have to disclose that I don't have any involvement with any products that are discussed in this seminar, although I do have funding from National Institute of Allergy and Infectious Diseases, NIDDK, and most recently National Institute of Aging as a disclosure. So our learning objectives, while I talk about HIV, dementia, and HIV-associated neurocognitive diseases today, I'm also going to give you an overview of the way our clinic works and the way we approach patients more from the HIV side as opposed to maybe the neuropsychiatric side, so you get a better idea of the way we work. We have a Center of Excellence for HIV/AIDS care. It was established really over 20 years ago. It is a multidisciplinary center focused on the care of HIV people infected in our area. It serves about 500 clients actively currently, and it is funded by the state and by Ryan White. It just keeps turning off. Maybe we are designated a 340B clinic, which means that we are a federally funded clinic that are eligible to get basically subsidies if we purchase medications for our patients, which we do, and all the money that comes back to that helps keep our clinic going. We do have quite a lot of people that are involved in the Centers of Excellence, including multiple MDs. We have a nurse practitioner who actually does primary care for our patients in addition to HIV care. We have a medical care manager who deals with insurance issues, a retention specialist who will go after patients that are disappearing from our clinic, who fade into the background. We have to go back and find those people that are HIV infected. We have a social worker for many, many reasons. And we have a medication adherence nurse as well to help with keeping people on track with our medications, which, as you know, for HIV are forever, at least right now. Can you all hear me? So we have multiple active trials at the Centers of Excellence. Many different groups kind of tap into our clinic. I'm the most notorious for this. We've been getting blood and specimens on our patients for over 14, 15 years now. We have thousands of specimens data banked and frozen in liquid nitrogen in our laboratories to study different immunologic aspects of people with either HIV infection, HCV infection, or co-infection. So we're very active in that, and that has been the crux of our translational studies that have helped us get funded, because while many people can study basic molecular mechanisms, not a lot can get to patients, and we can. So I think that's helped us a lot in terms of translational approaches. We're also looking with Dr. Moore right now at the prevalence of HAND, HIV-associated neurocognitive disorders. We have some pharmacokinetic studies that are ongoing looking at genetic variation in different medications that our patients are taking with the College of Pharmacy. And we're looking at end-of-life needs amongst our people living with HIV/AIDS. And this is a NIH-funded study out of University of Tennessee. And I'm working with Sadie Hudson, who's a nurse practitioner there. So these are just some of the things going on. We have many things on the horizon as well, so we're excited as time goes on. I wanted to kind of present how we approach our patients from the HIV side as opposed to maybe the psychiatric side. We do, of course, have a neuropsychiatric clinic for our HIV patients, a psychiatric clinic, but more from our side and what we do when we first see a patient. So I'm going to present a patient, Jerome. This is a 54-year-old man who underwent routine HIV testing after a previous partner was found to be positive, and he had a negative HIV test 8 years ago. His HIV ELISA was positive, and ELISA is an enzyme-linked immunoassay. It is a very sensitive assay. Sometimes it's a little overly sensitive, and it loses some specificity. Because of that, we can see false positives. Even people who donate blood can have a positive HIV test and not truly have HIV. It can be nonspecific sometimes. So we do a Western blot, which is a much more specific test, and in this particular case, the person had all of the antigens present that indicate that this person had chronic HIV infection. The viral load testing, where we actually measure the amount of virus in the blood, revealed a viral load of about 10,353. And his T cell count, which is our surrogate measure of immunity, showed that his T cell count was 3. Now, I can tell you, when I first started, we didn't have viral load testing. We had CD4 testing, which was about all we could do. And it was very difficult to treat these patients, say 15, 20 years ago. But having the viral load and the CD4 count has changed everything for HIV. It's allowed us to really develop true virologic control for our patients. I can tell you that a T cell count of 3 is not good. A normal T cell count is anywhere from 600 to 1,500. Most people start at about 1,000. 3 indicates advanced AIDS. So this is what it'll actually look like when it comes back to me. You can see the T cell count 3 up here. viral load about 10,000. That's actually a low viral load. Viral load highly correlates with disease. No other disease does a viral load correlate as much as HIV. If you've got a high viral load, you have a high chance of dying. If you have a low viral load, you have a low chance of dying. It's very, very clear from many, many cohort studies over the last 20 or 30 years, 20 years. So once you come in to see us, you're not just going to see me. It's not like you just come in and see the HIV specialist and you put you on some medicine. We have kind of a all-encompassing clinic, and once you come in, you're going to see a whole group of people, and every time you come in, you're going to see a whole group of people. So at the center of this is, of course, the patient, but you're going to see an HIV provider. We may or may not provide primary care, and more we've been providing the primary care for our patients because we understand them better. We understand the stigmas associated with their disease. We understand the drug-drug interactions, which are plagued by our medications. So we've been taking more of the primary care aspects of their care over. And the patients like it because they come to one place, and it's a one-stop shop. They're going to be meeting perhaps, often, their psychiatric provider, be it a psychotherapist or a physician as part of the Department of Psychiatry. And then they're going to meet a lot of people from the COE staff, including all the people I described, and they're going to help them with their home assessments, with their medications, with their transportation, with their insurance. So we provide a lot of kind of global care for our patients so that we can keep them in care, because keeping them in care is the absolute most important thing if we want to keep them alive. If they're out of care, we know every study, there was just a study this week that showed if you fall out of care, if you miss appointments, you're much more likely to die. So we try to keep them in care as much as possible so that we can get them their medications and get them the help they need to keep them physically and mentally safe. This is what we do upon initial evaluation. Every single person has a genotype of their virus. We can actually take their virus and figure out if it's sensitive to all the medications we have. We have 30 medications now. We use maybe a handful of those, but we have 30 that are available, and they've gotten much easier to give to our patients over the years. But we have to know that they're sensitive because a significant amount of people are resistant to the virus, resistant to our medications when they walk in the door. So we test every single patient, and this is what I love to see. I like to see a lot of green because then I have a lot of choices. And this isn't even all of the medicines we have to offer them. This is what I don't want to see. This was from a 16-year-old who was resistant to everything but was born with HIV and was given lots of different medications that weren't very good and not very well and not dosed well because as people grow up, you need to change your doses, and they didn't. And so you can see what happens to that. And he is still in my clinic, still alive, and still a huge challenge for us. I saw him 2 weeks ago. So this is what we want to see, though. Upon treatment, you see their T-cell count comes up. I'd love to see that go to 1,000. Some people do, some people don't. But as long as they get above 200, which is our magic number for developing very bad infections associated with HIV, as long as they're above 200, I'm happy. This is the most important thing. His viral load was less than 50. Now we can go down to even less than 20 copies per mil, which is what we call undetectable. And we know that once we get them undetectable, their chance of opportunistic infections all but disappears. And they become much more healthy. They'll gain weight. They'll come back to what they would have been without HIV infection. You know that HIV infection is worldwide. We have an incidence in this country, or a prevalence of about maybe 0.9 to 1%. But throughout the world, there are very many areas of kind of hot spots for HIV, with the former Soviet Union being a big one now. Many of these places don't test, so we don't really know, because they don't want to know. But I think that we've improved our global approach to HIV over the last decade, and we're doing much better in Africa than we were before, for example. But it is not going away. We do not have a cure. I don't think we're anywhere close to a cure. And I'm not particularly optimistic that we'll ever be able to do it. I want to. I'm writing grants to try to study it. But it's a very difficult virus, a very, very tricky virus, and I'll talk a little bit about that. But it has a lot of ways to get away from us. We know that ongoing viral replication equals progression of disease. You stop the virus, their disease won't progress. And we get people undetectable often within a few weeks. Their T-cell counts will improve. But the problem is you're stuck with then somebody who is immunologically suppressed, but not necessarily non-inflammatory. Many of these people still have markers of inflammation going on all the time. And what we know from infectious diseases in general is that you don't want chronic inflammation. It's not good for a lot of different reasons, and I'll talk about some of those reasons. This is what everybody learns kind of when I teach the medical students and residents, and everybody focuses on this end, which is the AIDS and death. And this is where the viral load up here, the HIV virus in the blood is actually quite high at the time of death, and the T cell count's quite low. But you have to remember that this is a spectrum of disease that progresses over many years, usually over a decade. Some of my patients over longer than a decade. So they start out with a pretty good T cell count. They have acute infection, and it drops to a certain plateau. Everybody's plateau is different. Some people drop quite low and never recover very well. Some people are quite high. And that affects their progression of disease as they go towards AIDS. But in the vast majority of the people, in 95% of it, it is inexorable. They will progress towards AIDS, and eventually I'll have to deal with that. So the virus has a lot of advantages that we struggle with daily. It can escape from the immune response. So it makes mistakes constantly. So it has a lot of genotypic changes that allow it to hide from our cytotoxic T cells upon initial infection. It can escape by phenotypic changes. It can become a non-syncytium to a syncytium-inducing virus, and syncytium-inducing viruses are much harder to go after. It can overwhelm the immune response, and we've actually published quite a bit on this, and the concept of cytotoxic T cell clonal exhaustion. After time, the immune system just gives up. It doesn't even try anymore. It upregulates all these receptors on their T cells that says, look, we're tired, we're not going to work anymore. And at that point, they really don't do well. And we're stuck with chronic infection. And then it's able to persist in privileged sites. And I think from a neuropsychiatric point of view, this is a very important concept because the cells in the CNS are highly protected and are clearly infected. So that's a problem. We have latently infected lymphocytes. We have virions and trapped in lymph nodes. And we have, I believe, reservoirs within the CNS and in the gut that are very hard to get to, especially the CNS. And many people are trying to figure out, how do we measure that? How do we go after that in order to get rid of that reservoir? They've tried things like giving people IL-2, which is not pleasant, and interleukin to try to activate lymphocytes. Didn't work. They've tried lots of different ways. So we're trying to come up with new mechanisms. We're looking at controlling microRNAs. MicroRNAs can appear to be able to control some reservoir formation. So that's what we're looking at. So what determines if the virus is going to replicate and who will progress? It's kind of a combination of host viral effects. There are T cell responses and chemokine receptors and age and gender and all these things that are part of the host. For example, I have some patients that never progress. They're rare, but they have mutations in their chemokine receptors and they just keep on going on. Their T cell counts are fantastic. Their viral loads are all but undetectable, but they have the disease. They will never die of HIV, based on what I can see in my patients. But there are also viral subtypes, genetic mutants, there's resistance. All of these tell you who's going to progress. There are cofactors like co-infections, nutrition, immunosuppressants. For example, HCV infection, not good to have with HIV. It definitely is not good for the immune system. Most co-infections are not good to have for HIV. A little bit about the viral life cycle so you can understand how we treat this virus now. Remember that HIV is a retrovirus, and that's really the problem. It is a retrovirus, so it goes from RNA to DNA to RNA. And that DNA intermediate here is able to intercalate into the host DNA. Any of our viruses, and we have quite a few chronic viruses, any of our chronic viruses that can get into the host DNA are very difficult to eradicate. Think of EBV, CMV, HSV, VZV, all the herpes families intercalate in, we can't get rid of them. HIV is able to do that too. We know that once it gets in, it has to use a reverse transcriptase in order to turn into DNA. It gets integrated with an integrase. It eventually develops proteins that require a protease in order to process the new virus. We have drugs for every one of these now. We have a dozen different ones that target the reverse transcriptase. AZT, the oldest drug that you all know about, originally was a target for the reverse transcriptase. Integrase inhibitors are new. They're very popular. They're very non-toxic. We've been using them a lot in the last couple of years. We've got lots of protease inhibitors. So we use combinations of these drugs. It's a cocktail, you've all heard about this, in order to control viral replication. We usually need at least 2 classes of drugs to completely control the viral replication. And we know that in doing that we have declining morbidity and mortality, and it happened almost immediately once we had highly active antiretrovirals, which some people call HART or ART, antiretroviral therapy. Once we had highly active treatments, patients started dying. When I started, most of my patients died. If I got a new patient, I had one who died the next day. It was constant. And that almost never happens anymore unless they don't take their treatments, unless they refuse therapy. And you can see just the data on HIV progression. Once we hit 1996, the first protease inhibitor, we started really seeing much less death and much more use of medication. So, and opportunistic infections all but disappeared. When we see opportunistic infections now, they're usually in relation to people that have not taken their medicines, and they just won't take them. And you'd be surprised how many patients we have that don't want to take anything, even if they don't have a side effect with it. And there's a lot of different reasons for that, but they do go on to die. I've got at least a half a dozen right now like that, and a couple in the hospital right now. So now we have our patient that we're taking care of. We've kind of enveloped them in the centers of excellence. They're seeing all of our people, and they're stuck with us for many years because we get them undetectable, their T cell counts are fine, we give them their medications, but they have started to develop long-term complications of just having chronic HIV infection, even if it's undetectable. We've seen neurocognitive dysfunction, which of course I'm going to talk about, much more bone disease than we expected, lots of dyslipidemia, lots and lots of cardiovascular disease, way more than what's compared to healthy people of their same age, cerebrovascular disease at earlier ages, and renal dysfunction. Many of these, you might think, and I believe, are almost age-related. It's almost like they're aged. And a lot of studies in lots of different domains suggest that. It's like they're aging too quickly. And I think that is a function of chronic inflammation. That is my opinion. I don't know what the real story is, but that's what I think it is. So let's talk a little bit about HIV-associated dementia and HAND. We saw neurocognitive decline a lot in the early days of the HIV epidemic. It was really easy to see. They came in with dramatic dementia because they had low T cell counts, lots of virus, and it usually was in people with AIDS. And when we see it still to this day, when you see true HIV-associated dementia, it's people with AIDS. But what we're learning now is that it's really more of a spectrum of neurocognitive disorders, and I'm sure you've talked a little bit about this because Dr. Goodkin is quite the expert in this. It is really a panoply of illnesses that is called HAND, HIV-associated neurocognitive disorders, including HIV-associated dementia, which we just talked about, but also asymptomatic neurocognitive impairments and then mild neurocognitive impairments. And all of those have very particular kind of definitions that the neuropsychiatric community has helped develop, and they have called this criteria the Frascati criteria. So if you look at this, and you can see that in order to be diagnosed with these, you're going to have problems in several different areas, almost always in at least 2 cognitive domains. And depending on whether or not you have impairment in activities of daily living or no impairment versus lots of impairment might define whether or not you have HIV dementia versus asymptomatic neurocognitive impairment. But you do have to have it in at least 2 cognitive domains, and I'll talk a little bit more about that later. Why do we care? So we have some people that have some neurocognitive dysfunction. Do we really care? Well, we know that it's associated with lower medication adherence, which I told you, adherence equals life for these people. If you're not adherent, then you're not going to live. There's a reason that I pay somebody to just deal with medication adherence. There's decreased ability to perform complex daily tasks. They have poorer quality of life, difficulty obtaining employment, increased risk of dementia and death, and its prevalence is expected to rise as other age-related diseases increase. So we have to care about it because we have a large population of people sitting out there getting older all the time. So this is a primary neurocognitive disorder.
It is not a side effect of something else. It is a primary neurocognitive disorder, but it can be a little bit difficult to tease out from all the other aspects of neuroaids, because we have people that have addiction. We have people with mood disorders, epilepsy, seizure disorders, neuropathic pain. All of these are kind of part of neuroaids, as is neurocognitive impairment. But neurocognitive HAND is truly a primary disease, as opposed to all the secondary things that we see that can impact it, like people have had strokes, co-infections, malnutrition, substance abuse, huge problem. How do you tease that out in our population, which has a lot of substance abuse? Treatment-related disorders. So it's a challenge for all of us, psychiatrists or not. You should know, though, that patients that are on HART, highly active antiretroviral therapy, definitely do better. It seems to have led to a decline in the more severe forms of the HIV dementia, which is good. We don't see near as much of that, but the prevalence of less severe forms seems to have increased. And it ranges anywhere from 20 to 50%, depending on the tool that's measured, but most of the tools that I looked at were more like 50% than 20%. So it's consistently higher than the general population. And this is just some data looking at patients before 1996 and after 1996. And you can see that the HIV-associated dementia goes down once you're on, the population's been on HART, but these other ones appear to be going up. Its prevalence is actually quite difficult to estimate. There's a very large cohort of patients you might have heard of. They're quite famous in the HIV world, called the Swiss HIV cohort. They followed patients forever, and they studied them on HART and found that at least 69% of their total clinic population had some neurocognitive impairment. That's a lot. If you think about 7 out of 10 patients having some degree of neurocognitive impairment, that's difficult to have to deal with as a clinic. Of those, about 8% had HIV-associated dementia, but a large number of them had at least mild neurocognitive impairment. Other studies by other groups have shown very similar prevalences. This one had a prevalence of about 44%, of which most of them were actually asymptomatic. But they all have a fairly high prevalence of the disease, of the disorder. The pathogenesis is obviously multifactorial, and luckily I'm talking to a group that's used to dealing with multifactorial problems. But it's definitely multifactorial, but I think a lot of it comes down to, it all feeds into neuronal damage and neuronal dysfunction. You're not going to have this without some kind of neurologic damage. There's lots of things that feed into it. I think a huge part of it is CNS inflammation, but that's going to be at the core of HAND, and you should know that the virus can't just get across the blood-brain barrier by itself. They believe it gets through the blood-brain barrier through kind of a Trojan horse kind of mechanism, where the lymphocytes and monocytes are infected, and then they get into the CNS, and once they're into that protected space, they're able to activate macrophages, produce viruses, and then affect the astrocytes, the oligodendrocytes, the glial cells, the neurons, and ultimately end up with problems in the brain. We know that in data from acute infection that HIV appears to enter the central nervous system very quickly, certainly within weeks after exposure. There is some control in the CSF initially, but not very good. And most patients end up with detectable CSF HIV once they're chronic. You can find it, and if you can look at this at the days post-infection, these people, a lot of them have detectable HIV in their CNS. So it's in there. We know that HIV DNA recovered from brain tissue in cells from the CNS have, that HIV DNA is present there. And that suggests the possibility of a cellular reservoir, which I truly believe is there. I think that's one of the major reservoirs for HIV infection. Remember, when they're intercalated into the DNA, they're not active. And these are very long-lived cells, many of these cells. So they don't, as long as they're not active, you're not going to be reproducing virus, but it's there. It's going to be very hard to cure the virus, because someday it will wake up. In terms of its pathogenesis, there are two models. There's the direct model, where they think that viral proteins released to actually just go and kind of trash the neurons that are there and cause trouble, versus the indirect model, which I think there's stronger data for, where the neuronal death is mediated by inflammation, which is mounted by inflammatory cells against HIV infection and its associated proteins. And we know that the macrophages and the microglia in the CNS secrete a huge amount of inflammatory mediators. And You're probably familiar with many of these, but nitric oxide, superoxide anions, TNF, chemokines, cytokines that are normally there to be neuroprotective cause problems. We in infectious disease are quite used to the concept of the brain trying to protect itself but ending up hurting itself. Meningitis is a great example. Most of the problem with meningitis, bacterial meningitis, is probably the protective effect of inflammation that is trying to eradicate the bacteria. I think a similar thing might be happening with HIV, where it's trying to protect itself, but in the process you're going to have neuronal loss and neuronal damage. There are multiple host virus interactions that contribute to this. Whether or not you have AIDS contributes. How active your immunity is at the time, how much inflammation is going on. There may be some differences in some HIV subtypes. Drug resistance may be playing into this. How low your T cell count was at the beginning may ultimately affect it. If you're somebody who got HIV and did not have advanced AIDS, you may ultimately do better than somebody who came in with a T cell count of 3 like our guy did. And I think that's probably true. There are some genetic components that come into it, including a lot of studies looking at metabolic disorders and aging, and particularly the phosphorylated tau protein has been shown to be associated and contributing to it, vascular disease, malnutrition, and obviously co-infection. So all of these can contribute to HAND, but I think what they have in common, this is my opinion, is chronic inflammation. I think many of these have been associated with chronic inflammation, including metabolic disorders and vascular disease and aging. Chronic inflammation is the problem. Co-infection is interesting. It's incredibly common in our clinic. We have probably 20-25% of our patients co-infected with hepatitis C. They have similar modes of transmission, IV drug use. In some clinics, it's 99% are co-infected. If you have a high IV drug use inner city population, huge amount of co-infection. So it's a problem. Now, its effect on HAND is actually kind of controversial. It appeared to increase the severity, but not necessarily the prevalence of neurocognitive impairment in patients on treatment. But recent work from the Charter Group, and this was just published a couple months ago, found that neurocognitive performance by measuring global deficit scores didn't seem to differ in the positive versus the negative group. The Charter Group is a large cohort called the CNS HIV Antiretroviral Therapy Effects Research Group, and they've had a lot of publications in this area. So I'm not really sure where we're going to go with co-infection, and I think it's going to be hard to tease out some of the problems. How do we diagnose HAND? The European AIDS Clinical Society actually came out and said you need to screen everybody. And there's some people actually who are out there say, oh, we don't need to screen this at all. So there's always controversy in everything you do in HIV. They fight over everything. But they said, at the very least, you should be asking these questions. Do you experience frequent memory loss? Do you feel that you're slower when reasoning and planning activities or solving problems? Do you have difficulties paying attention in a conversation or reading a book or watching a movie? As a screening test, and if it's positive, that you get complete neuropsychologic testing. I personally feel if you're talking about a prevalence of anywhere from 44 to 69%, that we should be evaluating everybody for this, and as much as possible, as much as you can, get as good neuropsychologic testing as you can do. There are some barriers to that. It's time consuming, it's expensive. You have to have people who know what they're doing it, and that's why I'm so glad that we're working with Dr. Goodkin and Dr. Moore and your group, because you all know how to do this much better than I do. So we're hoping that over time it becomes a standard of care like so many other things are for us. I immunize every patient who comes in the door. They all get pneumococcal vaccine, they get hepatitis A vaccine, they get PPD testing. I think they need neuropsych testing because they almost all have some problem if you look close enough. Remember that the assessment has to include these domains: verbal and language, attention and working memory, abstraction and executive function, memory, speed of information processing, sensory and perceptual and motor skills. I'm not an expert in this, but you all are, and that's why we need you for these kind of studies, because they're time-consuming sometimes and difficult. There are multiple screening tests that are now available to do this, and many of them are actually quite easy to administer, but the cost of that is that it may not be as good. So you have to look at all these screening tests and think, well, what's the ease of use? what is the sensitivity and specificity for different kinds of hand. Some of them seem better for asymptomatic neurocognitive disorder, and some of them seem better for dementia. Some of them require user experience, so you have to know what you're doing. It's not just a survey. And it might differ based on the patient population that you're looking at. You know, a drug abuser or somebody who isn't very educated might not do well on one of these versus another. I think ultimately we as a group have to come up with what we think works best and what captures the most patients and most accurately describes them. And it may be a combination, and probably will be a combination of different tools, maybe even different ones than these. I would love to have something diagnostically that was better. I would love to have a neuroimage that would tell me exactly that they have it. Wouldn't that be great? For HSV encephalitis, I can look at an MRI and say, oh, you know, they've got temporal lobe involvement, enhancement. This is almost certainly HSV encephalitis. I can't do that much for these patients unless they have very bad dementia. And this is just an example of somebody with HIV-associated dementia, where you actually do see the white matter changes at that point because they're so progressed. There are some novel things coming out that I think are really exciting, but they're not kind of ready for prime time yet, and I know Norman's very familiar with a lot of these. There are different ways you can neuroimage. There's metabolic analyses like MR spectroscopy, which has had some nice data. PET scanning, I think, is very interesting with the recent use of ligands that are specific for microglial activation. I think that's very, very interesting because I think that's underlying what's going on. There are some functional analyses where you can actually measure volume, volumetric analyses, and diffusion tensor imaging. And then there's structural analyses, for example, MRI for blood oxygen concentration-dependent imaging. And that has been used and been able to show that the HIV seropositive patients appear to display patterns of older patients. They look like seronegative patients that are 15 or 20 years older when you compare the different MRIs. I think that kind of thing could be really useful to me in my clinical practice. And I think that will develop over time. There have been some serum markers that have been suggested to diagnose this. We know that RNA, HIV RNA and CD4 counts are quite useful. If you've got a low T cell count and a high viral load, we know that that correlates well with it, but most of our patients don't have that anymore. So in the heart era, they don't correlate as well with neuropsychometric performance. We still have people that aren't doing well even when they're undetectable. So that may not be the best serum marker ultimately. There are some measures of monocyte activation, and I've done these in my own patients for other chronic viral infections, but looking at soluble plasma CD14 in monocytes has been linked to impairment in attention and learning. We know that HIV DNA in monocytes appeared to identify a raised risk for HAND, so they had an increased risk when you had HIV DNA that you identified from their monocytes. And soluble CD163 appears to be elevated in HAND, even in those with good viral control. These are all more experimental things, but I think they're exciting, and I think they're things we could look at too as a group. We certainly have the ability to do any of these things with our Center for Inflammation and Immunity and your Department of Psychiatry. So I'm excited about exploring some of those things because we need them, and we can certainly do the studies. Treatment is difficult. So we know that systemic HIV replication is clearly a risk factor for cognitive impairment, so we have to stop HIV replication, and we know that RNA in the blood is independently associated with it. So we have to get rid of that, and we usually do. So we use HAART. And highly active antiretroviral therapy is currently the only treatment that is approved for HIV infection and has been shown to impact HAND. Treatment with HAART affects the incidence of HIV-associated dementia, but it can't prevent the progression of cognitive decline, at least in the studies we have. We've been interested in looking at CSF pharmacodynamics, and I've talked to Dr. Goodkin about this before. We have many different drugs. They all have they're very variable in their ability to penetrate the central nervous system. And you would think that if you can get in better, that you would be able to stop the viral replication that's going on in the brain, and you would be able to stop that inflammation, that those patients would do better. And that may or may not be true. When the Charter group looked at this, they looked at 615 patients, and they developed a CNS penetration effectiveness ranking. It's a scoring system based on our drugs. Some of our drugs are really good at getting in, some of our drugs really stink at getting in. And a high score was associated with lower CSF viral loads, with a cutoff score of about 7 associated with significantly smaller numbers of patients with CSF viral loads. So now that's believing, this whole score is predicated on the belief that CSF viral load is really what counts. And I think that is still, the jury's out on that. So here's just an example of this is the CPE score. And you can see a drug like zidovudine, which is AZT. AZT gets in really well. Efavirenz gets in pretty well. I would have thought it got in really well because our patients hate efavirenz. It gives them terrible nightmares and causes psychoactivation. They don't like it as a general rule. I would have thought that got in really well, and it gets in okay. But a drug like tenofovir, which we use in almost everybody, does not get in well. We usually use a combination of drugs, so we would have to add up these scores. So if you're on a drug called Atripla, which has been around for about 15 years and has been the cornerstone of therapy, Atripla is efavirenz, which is a 3, tenofovir is a 1, that's 4, and emtricitabine, which is where here, 7. So they're just hitting 7 with that drug, Atripla. So that score would be predicted to lower your CSF viral load based on this. Is it valid? Some people say yes. We know that drugs with low CPE scores are associated with high levels of HIV RNA in the CNF. Of course they are. That's how they did the study. It was set up that way. But we also know that some studies show high CPE scores are associated with improved cognitive function. And we know from switch studies where they took patients that were on drugs that weren't very good at getting in, had low scores, and we switched them onto the higher ones, that some of them had improvement in their cognitive function. And we've actually done this before. When we've had people with HIV, cognitive dysfunction, especially HIV dementia, we have switched them over to drugs that appear to get into the CNS better. But we also know that some observational studies have not shown an association between heart and with high CNS penetration and neurocognitive dysfunction. And we know that all the estimates of CNS effectiveness are based on the CSF. It does not reflect necessarily the PK of drugs in glial cells or in brain macrophages. How do you do that study? Yeah, I mean, it's hard to do that study. You'd have to get brain biopsies, and patients generally don't want that. And that's why I like some of these more interesting imaging studies that are able to look at activation of microglia. I'd love to combine the CPE score with that, with the scanning that can look at activation of monocytes or glial cells in the CNS. That would be a useful study. So, other treatments have tried but failed. So they've tried antioxidants and SSRIs, and you're familiar with your group's going to be familiar with all of these drugs. They've tried the statins. I thought the statins might actually work because they seem to work for everything else, right? But they didn't seem to work that well for preventing neurocognitive decline that much. Potential treatments that are out there include minocycline, a drug that I've been using for staph infections for years. It's always been known to be an immunomodulatory kind of drug. It's not just an antibacterial. It suppresses SIV in monkey brains by inhibiting an apoptosis-associated kinase, and it's in human testing now. So it's been looked at in lots of different chronic viruses. We actually looked at it with HCV about 10 years ago because it seemed to have an effect on HCV viral loads. They're looking at the role of EPO. They're looking at insulin-like growth factor, P38 MAP kinase inhibitors, calcium channel blockers. Many of these won't pan out, but I think at least they're trying because I don't think the problem's going away as our HIV patient population never gets smaller because nobody dies or not many people die. They just keep on coming in. And we have quite young people in our clinic as well. We've got many college students in our group. So to summarize, HIV-associated neurocognitive disorders are common in chronic HIV infection on antiretroviral therapy. Comorbidities, and in particular chronic inflammation, may be playing a role in progression of HAND. I think diagnosis is going to require more extensive neurocognitive testing batteries, which have varying sensitivity and specificity, probably combinations of those. I think novel imaging techniques may provide improved diagnostic ability down the road, and I'm excited about the possibility of using those. And I think treatment with heart will remain the mainstay. We'll probably continue to look at the CPE score, and we certainly as a clinic will be using medications that get in as well as they can to stabilize or improve the cognitive problems that we see with our HIV patients. I wanted to leave some time for questions and any comments that you all might have. Yes?
Yeah, Dr. Moorman, I enjoyed your talk very much. You had a slide about the mechanism of penetration of the HIV tuberculosis. And my question is, do we really understand what that mechanism is? And for instance, you showed in one of the second to last slides that EPO with the Quillen is an effective treatment.
They're studying it.
They're studying it. Well, I'm wondering if that has any role in viscosity with the hematocrit, and whether or not that has any role in the mechanism in which the virus penetrates, or if that might be an area to target for.
This is kind of gives you an idea, or even the next slide will tell you how it gets in, they believe, through a Trojan horse mechanism in cells. So it's cellular HIV that gets across the blood-brain barrier. So it's not a virus getting in through the blood. So it's getting in through the cells, which is going to be impossible to stop, I think. You're not going to be able to tell the difference between a normal healthy monocyte and a monocyte that is HIV DNA implicated. So I don't know if that's going to be a very good way to stop penetration of the CNS. I think the better thing to find drugs that get into the CNS already can stop the neuroactivation that's going on. But it's that Trojan horse concept. That's how it gets in. And I don't know how EPO is going to work here. I really don't. In terms of drugs tried, I don't know that they've been tried much. Carl, do you know?
The reason, that is, and this is a precaution in hand different than in Alzheimer's disease, is that acetylcholine is not demonstrated to be decreased as a neurotransmitter. In fact, dopamine is the primary neurotransmitter secreted in hand. So that's the reason that the acetylcholine inhibitors haven't been focused upon. NMDA receptor antagonists have been looked at, memantine specifically, which you would have given Alzheimer's disease treatment. Unfortunately, ACT. I should mention minocycline failed the ACTG, as well as a calcium channel blocker pneumonia. So a lot of negative.
Mostly negative. And I don't think that's surprising. I think it's going to be hard to find the thing that works. I don't really think we understand the pathophysiology that well, because we can't get into CNS very well without brains. There's autopsy studies where we can see that there's infection in glial cells, but I think on an ongoing basis, it's going to be really hard to study unless we find surrogate markers for what's going on in there. Surrogate imaging markers, for example. That doesn't seem to have the same pathophysiology. Now, our patients are aging, and that they're certainly not going to be at any less risk for Alzheimer's disease, maybe more, as they get older, but they seem to have a different kind of pathophysiology. So. Uh-huh. Yeah. They don't report. They're just not reporting. Probably because they're at again. So. All African countries have an increased incidence. So. But they have such a high mortality from other causes that I don't know how much the hand that we're seeing is going to be evident there until they have enough people on treatment for a long time. They've improved a lot in terms of their access to HIV medications, but they die from so many other things. They're still dying of malaria, on a routine basis, tuberculosis, diarrhea.
where they say there's a fair amount of HIV. I didn't see it being mentioned, showing, lighting up either in terms of color. Is that, again, underreporting or?
The whole concept of India starting to talk about that is a new thing. It's probably, they haven't been very open about it up until more recently, so I think it's probably just reflecting that.
The time delay?
Yeah, they haven't, but it's definitely there.
Yeah.
And I think they've been much more open about reporting it of late. And also the former Soviet Union, which they said they had 0 for years, and, it was clearly not the case.
I've been working in the HIV clinic with Dr. Elliott, and the patients that I've seen so far over the past year, one of the most prevalent complaints is social needs. Not having resources, not having finances, the stigmatization to get work, and also, I guess, in some ways not knowing of the availability of the types of care that's offered, such as what we can offer in psychiatry, as also in psychotherapy. And I guess my question is, what changes are going to come about with, now that Dr. Goodkin's here, and now there's a bit more integration, I guess? I'm not sure, but I was curious.
My hope would be that we definitely have more integration. Our team, as it is, the COE team, is fairly integrated. We know our patients really well. We know their needs. There's some things we can't provide them. I can't give them cold, hard cash.
Yeah.
I just can't. I can help them with their housing. I can direct them to the right places to get that. We can get all of their medications. There's not one patient who can't get medications. We help them with their insurance issues. We help them with their transportation. We meet with them for counseling. We have our social worker go to their house. We know their families. When we think they need it, especially if they need your all's help, we get them in with you all. We provide their primary care for them. So we're doing a lot for them. I can't do everything for them, but we can provide as much of a cushion for them as possible. Down the road, I'd like to see, from a psych point of view, I want to see more studies. I want to see where we're evaluating basically every patient who comes in for these problems and getting a much better idea of what our clinic is like here in Appalachia versus maybe other clinics. Reporting our experience. I'd like to do that. I think that would be an easy thing to do to start with. And then maybe do some of the more kind of fun and translational aspects that Dr. Goodkin and Dr. Moore and I are more familiar with down the road. That's what I'd like to see. It's a population that we own. Whether we like it or not, we own them. So we have complete control of them. I've done clinical trials in my population. They're fantastic for clinical trials. The ones we choose, they always come to their visits. We did the pneumococcal vaccine trial with the new pneumococcal vaccine, and we were the highest enrolling site. Within 2 weeks, we closed the study down because we had so many enrollees. They know us. We know everything about them, and so I think it's a great population to study from a scientific point of view. They've got a lot of interesting questions that are hard to answer, but that are kind of fun from my point of view.
They also seem fairly motivated for treatment, and once they can learn about it, and from what we've seen is that they do get better, significantly better.
Oh yeah, they definitely. If they come in with advanced HIV disease, you see a huge difference, and they'll often come in very, very wasted, very thin, and they'll come out pretty fat. They'll look like everybody else in Appalachia in a year or two. And they'll say that the medication's causing them to be fat. And I guess technically it is, because they're not wasting away from the virus anymore and they're eating like they would. That's why we're trying to combine our adherence nurse with a nutritionist, because we're having more trouble with obesity in our population than with wasting like we used to. So, but I do think there's a lot of exciting things on the forefront for us, and I think we're the right groups to look at it. So I think we can do a lot together.
In your experience, what type of psychological reactions do you see in the patients once they're informed that they do have some type of CNS effect? They're already dealing with being HIV positive, and then this is added on to it. And I wonder what's done to try to help them cope with that.
Well, my experience is they're not surprised. They usually they've known something was wrong, and they've been very concerned about it for a while. So most of the time they're not surprised. Now, we don't have that many people with advanced dementia anymore. We've got one right now, but he's in the hospital and refusing therapy, and he's been very, very difficult. But most of our patients have more of the asymptomatic to the mild, the MND. And those are the people that kind of know something's going on and they're worried about it because many of them have jobs. I have a guy, his job was to shuttle chemicals back and forth on a train from Eastman. So his job was to make sure the trains get to the places they're supposed to get to, and he made a mistake. And it was a very expensive mistake when you send a train to Seattle instead of to Florida. It was like $1 million mistake. And he attributes that to his progressive dementia and progressive decline. I think many of his problems are actually medication related. We keep in mind many of our patients are on things like Lyrica, gabapentin, pain medications, anxiolytics. All of these contribute to seizure medicines. I mean, some of these seizure medicines can be very difficult for us to deal with. They have pretty impressive effects on their cognition, I think. So it's hard to tease them out from what's dementia and what isn't. So, but most of the time, I'd have to say they're not that surprised, and they want to know what to do about it. And we counsel them as much as we can, but many of these things I can't do about. They do trust us, though, because we're with them all the time, I think, for the most part. They trust us as much as anybody else, often more than their family members. So most of these people come from difficult social situations. They didn't get HIV out of the air. They almost every patient we have has a dual diagnosis. That's why I love that psych has evolved, because everybody has it. Even if you don't see it, it's there. And if they didn't have a diagnosis, a dual diagnosis, they still need counseling because of their stigma and their chronic HIV infection. Oh, I think they're pretty available. I think most of those scales are pretty easy to use. Most of them are pretty easy to use, but you do have to decide what you're going to use, what tool you're going to use, what you're trying to measure. And Norman can talk about all the scales that they're using now.
Your story about the train situation made me wonder, are there any published guidelines for avoiding fitness for duty, safety sensitive work, so forth?
No. Not any more than you all have for people that have cognitive impairment.
How do those issues interact with special provisions for confidentiality in the population?
Well, we can't. We're very confidential with our patients. Nobody knows about their disease. They're not allowed to discuss that with anybody outside of somebody that they've allowed us to do it. We have to get a signature from them that said that we can talk to that person. So outside of, somebody having a car crash or something like that, we couldn't do, if somebody were impaired with seizure disorder, something like that, we can do something about that, but can't reveal their diagnosis to pretty much anybody. Even
Jonathan,
even other care practitioners.
This is Norman. I just thought, since you mentioned what we're doing, I'd tell the audience, we're using a self-administered computer assessment of 14 domains of cognition. And it's a small study at this point. It's a pilot study. So we looked at 30 of your patients, just people coming in. There was no selection of patients. And I guess I wasn't really surprised, but in a way I was, that all 30 of them have got cognitive impairment, even those that didn't realize they had. But this is a very sensitive instrument. And so I think you can pretty much assume, from our small study, that all the patients who've got HIV have got some cognitive impairment. And that backs up a study I did when HIV/AIDS had just arrived in medicine and people were very of these patients. And we did an electrophysiological study. It was a quantified EEG study. And even when psychological assessments, neuropsychological assessments were normal, we were picking up physiological, neurophysiological abnormalities, and especially in the frontal lobe, we could measure them and see them. So I think that this is something that we in the research world have to look at more carefully to see just when does it appear. And the patients, by the way, that I studied were not AIDS patients. All they had done was converting over to being HIV positive. And even though they were just HIV positive and were not complaining of symptoms, they already had quantified EEG abnormalities. So it sets in very early.
Yeah, and you saw from the CSF studies that it's there way in the CNS. So I'm not surprised at all that you found problems with almost all the patients.
You mentioned stigma earlier. Working in this area, I know, like in my thesis lab that I'm in right now, I'm an undergraduate student. We study stigma a lot, and I know that there, in the past, especially in Appalachia, has been a significant amount of internalized stigma regarding HIV. Have you seen a decrease in the stigma and, I guess, an increase in people seeking help for HIV in the past, like, however long this study has been going?
No. I mean, the stigma is not. The stigma is still the stigma. It's, and I don't think it's just Appalachia. I think there's a stigma against, the HIV and all that goes along with the lifestyles and the things that put you at risk for that. So the stigma is still a major problem for us, and it does affect access to care to some extent. We've been able to get more patients into clinic earlier because people are testing more. We have lowered the threshold of testing out in the community in general, which is good because the Department of Health and Human Services came out with guidelines that said, look, you really need to be testing everybody at some point. And that's helped get more people in, made it more open. Primary care doctors are doing it. We picked up a lot from the OBs. The OBs were the first to do all standardized HIV testing on all their patients before anybody, they would demand it before it was allowed. They demanded that they have HIV testing, and we were able to really get those people into care, and we still do, very early, and we're really on top of those people because we're to be negative. We haven't had a positive baby here because we treat the mom. But we've gotten people earlier because of that.
You had mentioned one of the younger people, I think, patients you had, whatever, who developed resistance. But a related question I had, it was if patients, or I guess the fetus is exposed intrauterine, again, given the development of the nervous systems happening at that point in time, is there any implications in terms of cognitive development and or cognitive impact and or progression of neurocognitive functioning then over the course of
That's a great question. So pregnancy is kind of an odd thing with HIV. In the setting of treatment, we see very few babies, less than 2%, less than 2%. If they're undetectable at the time of birth, will go on to have HIV, the baby. Most transmission occurs at the time of birth. In utero, the baby, the fetus, is actually fairly protected. There are a very high viral load. There is some crossing of the placenta, and those are the babies that can be infected in utero. But that's less common for us to see. Most of the time, it's at the time of birth. So, for example, if I have somebody come in with a high viral load or high enough viral load that has not been on treatment, we do a C-section, and their chance of transmission is less than 2%. So most of it occurs at the time of birth. So and those babies turn out fine. I don't think that they're going to be any different than any other baby. We know that babies that are HIV positive don't do well. I mean, I think they're going to definitely have, I would be unsurprised if they have significant problems as they develop. We certainly have seen that with I have mostly teens and early 20s now as they've grown up, kids, and every single one of them has problems. Now, they have problems maybe for a lot of reasons. Most of them are orphans. Most of the parents are dead. They were born and their parents are both dead. And they come from tough backgrounds and they weren't very good with taking medications. And there's lots of things that play into that. But they all have pretty significant neurocognitive dysfunction, I would say. Every single one of my kids that have now grown up or are in their teens. So we really try to avoid the babies getting infected. We're on them like white rice. I mean, the social worker all but lives with them. And it's almost like directly observed therapy. And if they skip an appointment, we're at their house. I mean, because they're the most important. We've got it set up with high-risk OB. We go down there, and it works out pretty well. But luckily, the OB is screened for us. I mean, I think probably we should be screening more, and we certainly try to. The VA has now made it so we screen everybody at least once to try to pick up everybody early, because early treatment seems to be so much better to prevent some long-term problems like dementia. Well, thank you very much for your time.